Okay, everyone, we are going to go ahead and get started. We might get a couple more that trickle on as the presentation continues, but good afternoon and thank you for having me this morning. My name is Lautenschlager and I'm a CSTE Applied Epidemiology Fellow working in the North Carolina Division of Public Health, Injury and Violence Prevention Branch. Today, I'm going to be speaking on alcohol use, risk, and related harms to underage drinkers and adults in North Carolina. And I am accompanied today by Mary Beth Cox, who is a substance use epidemiologist in the branch, and she's going to be helping me manage the chat function throughout the presentation. So if you have any questions, please feel free to drop those in the chat, or if you raise your hand, they will be able to unmute you. So a brief overview on the topics we're going to cover today. First, we're going to review some definitions regarding alcohol consumption, and more specifically, excessive alcohol consumption, just to keep us all on the same page. And then we'll touch on excessive alcohol consumption and the surveillance that North Carolina routinely conducts and how we disseminate these data, primarily through our alcohol data dashboard. So what classifies as excessive alcohol consumption? So to start with a bit of background, excessive alcohol use is known as binge drinking, heavy drinking, any alcohol consumed under the age of 21, and any alcohol that is consumed by pregnant women. Binge drinking is defined as any one occasion where a woman consumes 4+ drinks, or where a man consumes 5+ drinks. And heavy drinking is defined as 8+ drinks a week for a woman, whereas for men, heavy drinking is defined as consuming 15 or more drinks per week. And as although this is not defined in the slides, the thought of counting drinks comes from one standard alcoholic beverage that is either 12 fluid ounces of beer, about 8 fluid ounces of malt liquor, 5 fluid ounces of wine, or about 1.5 fluid ounces of distilled spirits, such as gin, rum, tequila, whiskey, or vodka. So excessive alcohol use, which again defined as binge drinking, heavy drinking, any drinking by pregnant women or those under the age of 21, is the third leading preventable cause of death here in North Carolina. Excessive alcohol use contributes to both acute outcomes, such as poisoning, motor vehicle crashes, or other injuries, and also chronic health outcomes, such as cirrhosis, liver disease, and cancers. In 2020, there were almost 4,900 alcohol attributable deaths, both indirectly and indirectly attributable to alcohol in North Carolina alone. And each year, excessive alcohol use costs North Carolina over $7 billion. So the North Carolina Division of Public Health conducts routine surveillance on a variety of alcohol-related harms. And here we're going to explain some of those types of surveillance that we conduct and how they help us expand our prevention efforts. So first, we're going to talk about some survey data. In North Carolina, we use data from both the Behavioral Risk Factor Surveillance System, known as BRESS, and the Youth Risk Behavior Surveillance System, known as YRBSS. So first, we're going to talk about the BRSS, known as BRESS. So this is a randomized telephone survey that is conducted on an annual basis of North Carolina adults 18 and older. And this asks questions about health behaviors, including binge drinking, and other health topics include preventative health practices. Some of these questions include, health screenings, smoking habits, seatbelt use, cardiovascular disease, cancer, diabetes, and other various injuries. And the State Center for Health Statistics posts annual analysis of these data by each question, by sex, region, other demographics, if you would like to explore this further. And the most recent data year that is available is the 2020 year. And due to the COVID-19 pandemic, some data years are taking a little longer to close out, analyze, and process, which is why we're still on 2020. And the data that I'm about to share with you here all come from the BRESS from North Carolina State Center for Health Statistics. So over the last 6 years, we see that North Carolina adults, these are 18 and up, reported binge drinking at an average of 14%. And we see this number is fairly steady throughout the years, with a high of 15.5% and a low of 13.5% over the 6 years. And as a reminder, binge drinking is adult men having 5 or more drinks on one occasion and adult women having 4 or more drinks on one occasion. And here in the years of 2018 and 2019 and 2020, North Carolina males reported binge drinking more often than females. Although the total was roughly 14.1 over the 3 survey years, males had a reporting percentage of roughly 18.6%, whereas women had a average reporting percentage of about 10.1%. And these differences are seen fairly dramatically in the chart here, with the percentage between males and females over 2 times as much in 2018, a little over 1.5 times as much in 2019, and in 2020, we see males reporting binge drinking about 1.7 times as much as females. So now we're going to dive into the YRBSS, which is the Youth Risk Behavioral Survey. This is completed in schools on a biannual basis, so in the spring of odd number years. And because this study is executed in schools to minors, not all parents allow their children to participate, and it is not mandatory for all schools to participate. A variety of topics that are covered within the survey, just like the BRESS, including violence, personal safety, physical activity, nutrition, mental health. It goes into tobacco, drugs and alcohol, protective factors, and other sexual behaviors. Other health topics can include asthma, indoor tanning, sunscreen use, food allergies, everything in between. I'd also like to note that the survey only covers those attending schools in North Carolina, and there's still kind of an underage drinking population that's harder to collect data from because the BRESS does start at 18 plus age groupings. So we do kind of have that between 18 and under 21 still group that's a little harder to pinpoint. But all data I'm about to share with you here is going to be from the YRBS, shared from the North Carolina Department of Public Instruction. So let's dive into some of this data on reported alcohol consumption among North Carolina high schoolers. So this is at least 1 alcoholic drink in the past 30 days. And the reported alcohol consumption in these high schoolers has steadily decreased over the last 3 survey collections, which is good. But remember that any alcohol consumption under the age of 21 is considered excessive alcohol consumption. Now we're going to break that down into sex. So more high school females report alcohol consumption than do high school males. This is again 1 alcoholic drink in the past 30 days, although the overall trend has decreased slightly from 2017 to 2019. Reported consumption is still more common among female high schoolers than male students. And the trend in both reported female and male alcohol consumption has decreased. In 2017, the percent of high school females that reported drinking was about 1.1 times more than high school males. And in 2019, females reported drinking more than 1.3 times more than high school males. And even though the overall percent of reported consumption decreases in both males and females, the difference is larger here in 2019. So North Carolina high school students that reported having their first alcohol consumption before the age of 13 has also increased over the past 3 survey collections. This alcohol consumption is defined as having their first drink of alcohol other than a few sips before the age of 13. Among North Carolina high schoolers, reported initiation of alcohol consumption before the age of 13 years old had an average of a 14.8% change. And here we see that breakdown again by sex. We see that more high school males report having their first alcohol consumption before the age of 13 than high school females. And although male overall trends decreased from 2017 to 2019, male high schoolers reported a much higher percentage than females in 2019 than in 2017. In 2017, the percent of high school males that reported initiation of alcohol before the age of 13 was 1.4 times more than high school females, whereas in 2019, males reporting initiation of alcohol consumption was 1.2 more than high school females. Remember again, this is a full alcoholic beverage before the age of 13 years old. And this, of course, means that this percentage of youth that are reporting having these drinks are at risk for other developmental and behavioral issues. Another question that's included in the YRBSS asks about reported binge drinking in youth, which is 4 or 5 drinks of alcohol within a few hours for females, or 5 or more drinks of alcohol within a few hours for male students on at least one day during the 30 days before the survey was taken. So this question only started to be asked in 2017, which is why there's only the 2 years of data here. But this reported number was almost identical in both years of survey data. However, of the 26.5% of students that reported drinking any alcohol at all in 2017, which was shown on the previous slides, 53.2% of those students reported binge drinking. And in 2019, of the 24.2% of students that reported drinking at all, 48.4% of them reported binge drinking. And this tells us that if youth are participating in drinking or consuming any alcohol at all, that they are more than likely binge drinking. And despite total binge drinking trends staying steady across 2017 and 2019, we do see an increase in reported female binge drinking among high schoolers and a decrease in male reported binge drinking among high schoolers between the two survey years. When broken into grade level, we see a pretty dramatic increase here in the number of students who report binge drinking as they age. In fact, we see kind of like a cell phone tower visual in 2019 high school 12th graders or seniors almost doubled the number of 11th graders who reported binge drinking. And in 2019, 12th graders alone showed to have a 3.7% increase in reporting, despite the overall reporting percentage staying the same. And for those of you who may be interested, I kind of mentioned it earlier, but the BRESS data also stratifies data by a bunch of different things such as veteran status, income, education, etc. However, for this presentation, I did try to focus mainly on the youth underage drinking. All right, so now we're going to talk a little bit about the alcohol-related disease impact. So death data is also leveraged for surveillance through the CDC's alcohol-related disease impact, which I'm going to refer to as the ARDI methodology. The alcohol-related disease impact, ARDI, is a tool provided by the Centers for Disease Control that provides national and state estimates of alcohol-related health impacts. These are things such as alcohol-related deaths and years of potential life lost. There are estimates get calculated for 30 chronic and 18 acute causes of death using the alcohol attributable fractions, also known as AAFs. These alcohol attributable fractions measure the total proportion of deaths from various causes that are directly or indirectly attributable to alcohol consumption. And these ultimately indicate the extent to which alcohol consumption contributed to a health outcome, whether that be directly or indirectly attributable to alcohol consumption. And as science and literature evolve around these health outcomes, the CDC does release new updates that incorporate these updates, which then individual states are responsible for implementing. And if you were to just Google CDC ARDI, you would come across this page where you can then select your state and then choose what kind of report you're looking for, which would be alcohol attributable death, years of potential life loss, and alcohol attributable fractions. And of these alcohol attributable fractions, which is AAF up here at the top, some causes of death are acute and some are chronic. This then gets broken down even further. Acute alcohol attributable fractions are things you may typically think of as alcohol, or think of that alcohol could influence, including falls, motor vehicle crashes, and alcohol poisonings. However, the majority of alcohol attributable fractions cover these other chronic conditions, such as alcoholic liver disease, liver cancer, and pancreatitis. There are also subcategories within each acute and chronic classification that include 100% attributable to alcohol and indirectly or directly attributable to alcohol consumption. And alcohol poisoning is an acute cause of an alcohol attributable death, but is also a 100% attributable to alcohol consumption, or alcohol-induced pancreatitis are 100% attributable to alcohol consumption, while others, such as cirrhosis, certain cancers and strokes, are directly or indirectly attributable to alcohol consumption. And the difference there is that 100% attributable to alcohol consumption then gets a fraction of 1, and then these other fractions, such as cancer, strokes, cirrhosis, motor vehicle crashes, they get broken down into a prevalence expression, and there is a very long calculation that comes along with this that gives us their fraction depending on their age, whether they're male or female, and then that contributes to the overall ARDI estimate. So some of the acute causes of alcohol attributable death, just to give a little more explanation, directly alcohol attributable causes of death are deaths with a linear relationship between alcohol and the cause of death. And some of these examples, as you see here, are drowning injuries, fall injuries, aspiration, suicide, motor vehicle traffic crashes. And those 100% alcohol attributable causes are things such as alcohol poisoning and suicide by exposure to alcohol. Oh, and I did also want to mention on this slide that deaths with acute causes, many times they do have a BAC of above 100 milligrams per deciliter, and BAC is their blood alcohol concentration level. So that's how that can be determined.
Hey, Ty, is Mary Beth. I'm sorry to interrupt you. I just wanted to double check. Would you like questions as they come in, or do you want to wait till the very end?
I don't think I have a preference.
Okay.
I'm fine to go back.
I'm seeing Travis, I think it's Patterson. If you've got your hand raised, if you have a question and wanted to come off mute and ask that, or feel free to drop it in the chat, or maybe it was a mistake. It looks like the hand went down, so maybe it was just a mistake. I'll let you keep going, Ty.
Okay. Okay, and here for chronic causes of alcohol attributable deaths, again, we have the 100% alcohol attributable, which we see as a much larger list here, as well as directly alcohol attributable, which is a smaller list here, and then indirectly attributable to alcohol, which we did not see in the acute causes. And here, different 100% alcohol attributable deaths are things such as alcohol abuse, alcohol dependent syndrome, and other things that are 100% alcohol or attributable to alcohol consumption. And then some of the directly alcohol attributable deaths, we see things such as liver cirrhosis. And then in the indirectly alcohol attributable deaths, we see a lot of different cancers, such as liver cancer, pancreatic cancer, and also things such as hypertension and acute pancreatitis, as well as chronic pancreatitis, which were mentioned on that diagram that I had shown earlier. Okay, so this is showing the number of deaths within North Carolina using the ARDI methodology. So here we see in 2020, there were 4,897 estimated deaths in North Carolina that were attributable to alcohol. And this trend, as you can see, has been increasing over the last 20 years and is attributable to both or all three of those acute, chronic, and 100% alcohol attributable deaths. And if you look closely, you do see a pretty big spike there from 2019 to 2020. And you're probably already thinking this was largely contributed to the COVID-19 pandemic. And then along with this, there's also county level information on ARDI and other alcohol attributable deaths included in the Division of Public Health Alcohol Data Dashboard. There's also some PDF tables that are posted on our Injury-Free NC website, which also breaks down by chronic, acute, and total estimates from 2011 to 2020. So looking at ARDI data from the most recent 5 years, so 2016 to 2020, we can analyze by rates. So these are going to be rates per 100,000 North Carolina residents. These are also going to be of all years. So we see here that with these descriptive trends that males have a higher rate of alcohol attributable deaths at 58.3 per 100,000 population compared to their female counterparts that have more than half of that at 22 per 100,000 population. Rates of alcohol attributable deaths increase by age group, as you can see here on the right. And even though the percent of older adults who report excessive drinking is low, the rates of alcohol-related deaths are high among this group. And this is because with ARDI, the alcohol-related disease impact tool considers both chronic and acute causes of death. So like I was saying earlier, with all those different chronic causes, with cancers and other issues that can arise as one gets older, just from any alcohol use at all whenever they were younger. So that is why we see those bigger numbers as people age. And here we see the breakdown of that previous chart, but this is just under 21 by sex. So these are the ARDI estimates from 2016 to 2020. And we see that males under the age of 21 have a 3 times higher rate than females under the age of 21 of dying from an alcohol-related cause. And these are almost entirely related to acute causes of death, such as motor vehicle incidences, suicides, poisonings, drownings, falls, etc. And here we'll see that chronic and acute have very different age group estimates. And this is to just further showcase that the difference in acute and chronic causes of death very much affects different age groups. So although chronic causes of death do not impact the less than 21 age group, chronic causes of death have a very large impact on the rest of the population. But you'll also see here in this less than 21 on the right-hand side that that rate per 100,000 is what is affecting those males in the previous slide. So alcohol and other injuries. So North Carolina Division of Public Health also conducts surveillance to understand alcohol's contribution to other injuries. Our branch does a lot of additional and other surveillance. So I'm going to try to briefly touch on a little bit of all of it, but this is just truly only skimming the surface. And there are so many other avenues in which we monitor alcohol use and other consumption trends. So if you do have any additional questions after this presentation on surveillance, specific surveillance, monitoring, just please send us a follow-up email or reach out directly. So the CDC's safe prescribing guidelines. So when combined with some medications, alcohol can increase depression of the nervous system, and this can increase risk for overdose. So the CDC's safe prescribing guidelines tells us that there is absolutely no level of alcohol use that is safe for people using opioids, which is interesting because even though that is the case, from a scientific standpoint, more than half of the 4.2 million people in the United States who misuse prescription opioids also binge drink. So that can then contribute to some of our opioid overdoses as well. And to further expand on that, this graph shows overdoses and poisoning deaths that did involve alcohol as well. While the counts of all poisoning deaths have been increasing in North Carolina, we're also interested in these polysubstance trends, which are deaths that had more than one substance in their system at the time of death, which is found in toxicology screening. And as the number of deaths, or as the number of overdose deaths rises in North Carolina, unfortunately, we're also seeing a large number and an increasing number in those overdose deaths that are involving alcohol. So over the last 10 years, as you can see here, the percentage of alcohol involved in poisoning deaths has increased, reaching 18% in 2020. So we also utilize the North Carolina's violent death reporting system to capture information on alcohol's involvement in violent deaths. So our violent death reporting system provides a lot of very rich circumstance information that is collected from family and friends of the victim. These circumstance information can include things such as relationship problems, depression, previous suicide attempts, job loss, and many others. And we're extremely lucky to have such a robust reporting system here in North Carolina and to have abstractors that take the time to hand review every case and make sure we're getting very accurate information. We also partner with the Office of the Chief Medical Examiner, known as OCME, to gather toxicology information of what was in the system at the time of death. So on this slide are percentages of the number of circumstance information that was collected. So these are of all ages, and these show that men are more likely to die by suicide with a known alcohol problem, while women are more likely to die by suicide while misusing other substances. And here we see these trends are also, I'm sorry, I lost my train of thought. But here we see the trend or suicides of all ages in 2019 separated by sex. And we see that females, although they are much lower than males for a known alcohol problem, they are more likely to have a known substance problem or known other substance problem. We also do have this information available for youth. So youth here is defined as 10 to 14. So there is a little bit of overlap there. However, we do see a total of 8.3% of youth that died by suicide in 2019 had a known alcohol problem, and males are more than likely than females to have a known alcohol problem and die by suicide. On the contrary, 17.4% of youth who died by suicide had a known substance use problem, which males, or with males being almost 1.5 times more likely than females to have the known substance misuse problem. And North Carolina Division of Public Health continues to analyze the relationship of alcohol and violent deaths to give insight into the best prevention methods. Now we're going to go into alcohol involvement in crashes. So alcohol is also a really big player in fatal crashes. We see a large number of crashes in adults, which is what we would expect because of the sheer number of people. North Carolina uses a variety of data sources to monitor these alcohol impaired driving trends, and the North Carolina Division of Public Health partners with the Department of Transportation to analyze these crash data a little bit further. So in 2020, we see that alcohol was involved in 1 in 25 fatal crashes among all drivers. But also in 2019, we saw that teen drivers between the ages of 15 and 19 had alcohol involved in 1 in 10 crashes. So although the number of teens that actually have fatal crashes is a relatively small number, this 1 in 10 statistic shows us that a large proportion of these crashes involved alcohol, and all of these drivers were below the legal drinking age. So all of these deaths were preventable and should not have happened. The scary part is that this 1 in 10 stat is actually the lowest that it's been in years. And in 2018, that number was actually 1 in every 4 fatal crashes among teen drivers. So as it may seem like a small issue, due to just the small number, there's a very serious impact backing it. So going back to the YRBS, this slide compares the percentages of high schoolers that reported drinking and driving 1 or more times in the past 30 days. And these are them being the ones driving after having been drinking themselves. And if you remember from some of the earlier slides, females had reported drinking more frequently. However, males reported drinking and driving more frequently. We also see a large percent increase in this 12th grade column, which is kind of what we would expect because this is just when most teenagers are getting their license, their permit, they have access to a vehicle at this time. Then we also use the YRBS to look at percentage of students that reported riding with a driver who had been drinking over the last 30 days, whether this be a friend, a family member, just whoever, a driver that was under the influence. And in 2019, we see that 19% of middle schoolers and about 16% of high schoolers reported riding with a driver who had been drinking. And among each age group, trends are similar by sex, especially in high school. And if you think back to the previous slide, we see much larger reported numbers here versus those who were reporting drinking and driving themselves. And this disconnect is thought to be because youth are more likely to admit being a passenger of someone who had been drinking and driving rather than being the one who was responsible for operating the vehicle. And one way to reduce some alcohol impaired driving is through ignition interlocks. And for any of you who may not know, ignition interlocks are installed in cars of someone who has been caught for drinking and driving and requires having blown a negative BAC, a blood alcohol concentration, every time in order to start their vehicle. In 2019, 34 states required ignition interlocks for all offenders, which is seen in red here on this map. This is the evidence-based recommendation from the Community Preventative Service Task Force, which means there are significant resources that show when all drinking and driving offenders are required to have an ignition interlock, that drinking and driving is less of a threat throughout the state. Currently, North Carolina requires ignition interlocks for any repeat offenders convicted of alcohol impaired driving or any first-time offenders that have a particularly high blood alcohol concentration. And currently, there has been some momentum in the North Carolina General Assembly to change the interlock laws and bring North Carolina up to the highest recommendation, and that would require for all offenders to have ignition interlocks on their vehicles. And this momentum for this change has been largely led by the North Carolina Child Fatality Task Force. And we also track emergency department visits through our NC Detect, We track alcohol intoxication in those who are under 21 years old. We also track adult intoxication in addition to any alcohol use in those under 21 years of age, which is shown here. So if you look at the map here, these are under 21 years of old, under 21 years of age, and these are ED visits for just any alcohol use, and this is just 2020 alone. And these are the rates that have the different color scheme. And so this map shows us that Transylvania County, which is down to the western side of the state, is actually the county with the highest number of ED visits for this population. Transylvania County had 184.2 per 100,000 residents under the age of 21 that had come in for any alcohol use. Emergency department data provides insight into a different subset of alcohol-related injuries. And please note that these data are for ED visits that had any alcohol uses when residents were less than 21 years of age. And rate did vary greatly across counties. As you can see, we had counties that had, I believe there were 2 counties that had a rate of 0. I know one of them was Clay County. And then the state had an overall ED visit rate for this population of 69.4 per 100,000, and these are under 21 North Carolina residents. And now we're going to go into a little bit about our alcohol data dashboard. So a key part of prevention is data dissemination. In North Carolina's Division of Public Health surveillance efforts are best captured in our alcohol data dashboard. The dashboard does share evidence-based policies alongside North Carolina and county-specific data to present the problem and solutions. Our data is currently in the process of being updated right now, so I am going to share with you a little outdated data, but it is what is currently on the dashboard. So there are some things we can do to impact alcohol-related harms. This is the logic model that is the basis of our alcohol data dashboard. Alcohol control strategies like the system we have here in North Carolina, combining that with lower alcohol retail densities result in an overall lower consumption, which is then reducing negative health outcomes and economic costs. Surveillance efforts inform each of these pieces of this logic model, which gives it kind of a domino effect, as you can see here. The dashboard walks through the public health narrative of the acute and chronic impacts of excessive alcohol consumption. And we use many different data sets to tell this story. We use the BRESS and the YRBS data to give us the survey data on consumption. And then ED visits illustrate the impacts of the healthcare system and death data to get all the years of potential life lost. So we pull all of this together and that gives us the county level estimates. And then this is very helpful just for anyone who's curious and wants to explore the data dashboard. I see Mary Beth just dropped that link in the chat. And if you are curious and wanting more recent numbers, we should be having that updated hopefully here soon. So now we're going to talk about some alcohol outlet density rates. So these density measures the number of places where alcohol can be purchased in any given area. Here we're going to look at by county. So we look at the alcohol outlet density rate by an on versus off-premise outlet, where on-premise outlets are places such as bars and restaurants where alcohol is consumed on-premise. And off-premise outlets are things such as grocery stores, liquor stores, anywhere where people can purchase alcohol and then leave. And alcohol outlet density is associated with increases in many community level problems. These can be things such as neighborhood disruption, property damage, alcohol impaired driving, domestic violence, and child abuse. And we see many of the highest alcohol outlet density counties are those over here on the coast. So we can also use that alcohol outlet density by different demographics to understand and therefore address different disparities. So this is an example from work within Durham County. So as mentioned on the previous slide, on-premise outlets are places like bars and restaurants where alcohol is consumed on site, and then off-premise outlets are things such as grocery, liquor, or convenience stores where people purchase alcohol and then leave to take it wherever they are going. So here we see the demographic of those living within these alcohol clusters were meaningfully different than the population distribution of Durham County overall. So here over on the very left, we see that white non-Hispanics make up 42% of the overall Durham population, though only 26% of the population within off-premise clusters. And then Hispanic residents, which is over here on the right, make up about 14% of the Durham population, but 12% of the on and 21% of the off-premise cluster populations. And then Black residents, seen in the middle, make up roughly 38% of the Durham population, and 33% of the on and 47% of the off-premise cluster population. So we also have some community preventative service task force recommendations. So these are all evidence-based recommendations for reducing excessive drinking. As you can see, if you just look down the list, most of them are recommended, and these are things such as maintaining limits on days of sale. So here in North Carolina, liquor stores are closed on Sundays or holidays. We also see ignition interlocks there towards the bottom, like we had already talked about a little bit, regulation of alcohol outlet density, electronic screening and interventions. So the only thing that is actually recommended against is the privatization of retail alcohol sales. And that is one thing that North Carolina tries to continue, just to make sure that we are not privatizing these alcohol sales, and we're keeping it under the state's control. And that is all I have for you today. I can take any questions if there are any.
Thanks, Ty. I'm not currently seeing any questions in the chat. So if folks do have any questions, feel free to drop those in the chat, or you should be able to come off mute and ask any questions. Oh, thanks, Dana. Maybe you all can't unmute. So if you do have questions, just put those in the chat and I'll keep an eye out.
I can unmute them. Give me 1 second, okay? Let's see here.
Thanks,
That was
Holly.
Dana. Okay, I just sent a request for her to unmute. It looks like they're able to speak now.
Can you guys hear me?
Perfect.
Ty, can you go back to that slide? I think it was quite a ways ago. I didn't want to interrupt you in the middle. I was just curious what it meant. Suicide by and alcohol use. And so from like the VDRS, it was before this. It was kind of like I think it was like with the chronic causes and the acute causes.
Oh, yeah.
There's a big list.
This one?
Yeah, yep, right there. Can you kind of explain that suicide by and exposure to alcohol one?
Yeah, like this. Oh, and the 100% alcohol attributable. So that one is a little bit tricky. I honestly am not sure that I have a clear answer, other than that's what's in the ARDI methodology, and that is what they have us label it as. Mary Beth, I don't know if you have any other explanations for that one and how it differs from.
So that one's just not saying that alcohol was the mechanism, right? That's just saying that someone who died by suicide did have exposure to alcohol prior, right? I just wanted to make
No.
I'm sorry. Yeah, now my brain has been jogged again. Yeah, no. So suicide, that is actually where they had consumed enough alcohol to then die by suicide.
So the way to think about these, you're right there, Ty, that these are all the acute causes. So injuries, if you're looking at like firearm and falls and drowning. And so all of those on the right-hand side that are directly attributable to alcohol, like someone who maybe was consuming too much alcohol and fell and died as a result, that would be a death that would count as directly attributable to alcohol. If they had not been consuming that alcohol, they would not have fallen, they would not have drowned, whatever the mechanism of injury was. However, not every single fall injury or drowning or any of those on the right hand side involves alcohol, and so those are only directly attributable to alcohol. The 100% attributable to alcohol, every single those, it's basically unintentional and intentional, those two lines, alcohol poisoning. Every intentional suicide by consuming too much alcohol, 100% of those happened because of the alcohol. Is that making sense, Dana? So every single one of those suicide by alcohol or unintentional alcohol poisonings, every one of those would get counted as part of the ARDI methodology as an alcohol attributable death. And then you see suicide listed on the directly alcohol attributable, because not all, as you know, Dana, not all suicides include alcohol, but there are some that maybe alcohol is on board at the time of death, and it might have influenced that decision, but it wasn't the amount of alcohol in their system that actually caused the death.
Yeah, thank you so much for explaining that. I just wasn't sure with the verbiage. So that would be an intentional poisoning where the poisoning mechanism was alcohol. For
Yes.
suicide by and exposure to alcohol.
That's correct.
Okay, thank you guys.
I'll chime in quickly, and I'm curious if folks could drop in the chat like where you work or the population that you work with and kind of what your role is. Why were you interested in joining this? And I hope that this presentation today has kind of positioned us as a resource for you in your work, whether you work with the underage population or people of all ages. If excessive alcohol consumption prevention is part of your job, we're certainly a resource, and Ty did a great job of outlining all of those. Alcohol touches everything that we work on in injury and violence prevention, and then goes beyond the work that we do at injury and violence prevention. And so a lot of our colleagues in the chronic disease and injury section within the Division of Public Health are also tracking and monitoring alcohol's involvement in the conditions that they're concerned about. And so we're always available as a data source and a resource for any data needs that you have. Seeing some job descriptions roll through the chat. Thank you all for putting that there.
All right, any other last minute questions that people had? Okay, well, my email is on the slide, as well as Mary Beth's in the substance use data at dhhs.nc.gov is our substance use data email. So those can make their ways to us as well. Or like Mary Beth mentioned, if anyone has a data request or if they need more resources, if you want to go ahead and email the substance use data at dhhs.gov, that could make sure it gets its way to us as well. But if there's no other questions, thank you so much for your time and being attentive. And if you have any questions, feel free to email us.
Thank you both. I appreciate your presentation. It was very informative.
All right, thanks all. Have a great day.
Have a great day, guys.